The purpose of this presentation is to provide up-to-date and clinically relevant evidence-based evaluation assessment and intervention techniques for ankle pain with mobility deficits, specifically anterior ankle impingement. Anterior ankle impingement results from an impingement of the ankle joint by a soft tissue or osteophyte formation at the anterior aspect of the distal tibia and talar neck. Chronic lateral ankle instability and microtrauma during repetitive dorsiflexion is the most commonly accepted hypothesis to the development of both bony and soft tissue lesions. Diagnosis is generally confirmed by radiographs. On the left is an X-ray image of osteophyte formation creating a kissing exostosis, and the photo on the right is an MRI demonstrating soft tissue involvement. Lateral ankle instability is the target of treatment interventions. I think that research is currently lacking on diagnosis and interventions targeted specifically for conservative management of anterior ankle impingement versus utilizing CPGs formulated for chronic lateral ankle instability. Can you think of how treatment interventions may differ between chronic lateral ankle instability versus ankle impingement? First and foremost, it is important to make sure that the patient you are seeing is safe to be treated or if additional tests or imaging may be necessary. Review the Ottawa ankle rules if you don't already have them memorized. Now that you've determined that the patient is safe to be seen, you can move to your lower quarter screen, subjective and objective exam. Subjectively, you may find chronic anterior ankle pain exacerbated with dorsiflexion, pain with squatting, hill climbing, or stair climbing. Objectively, you may find decreased dorsiflexion range of motion and or edema. You can now move to your special test.
One of the few tests that we can conduct for anterior ankle impingement is the forced dorsiflexion test. This test was developed in 2003 and was not meant to be conducted alone. It should be conducted with a series of other tests, but the tests were not specified of what you should do. In order to conduct this test, what you're going to do is grasp the calcaneus, and your thumb is going to be at the lateral aspect of the ankle. The patient, of course, should be in 90-90 sitting, and with the opposite hand, they're going to maximally dorsiflex the talocrural joint. And a positive test is reproduction of pain at the anterior aspect of the ankle or an increase in pain at the lateral ankle.
There is a cluster of tests defined in a study by Liu et al. In 1997, which is now over 20 years ago, for anterolateral ankle impingement. The sample size of the study was small, with 22 participants. More recent studies have agreed with most of the items. However, lack of lateral ankle instability is now outdated criteria. A single leg squat is number 5 of the criteria, looking for reproduction of pain. The purpose of conducting a talocrural dorsiflexion mobilization is to improve dorsiflexion and proprioception. Decreased dorsiflexion can lead to compensatory patterns during mid-stance to terminal stance, which can negatively impact stance time and energy expenditure, as well as predispose the patient to other injuries. Dorsiflexion will be painful for your patient, so it is important to assess patient tolerance and adjust your line of force and patient positioning during the mobilization as needed. You can also progress this intervention to include mobilization with movement.
If the patient demonstrates a decrease in dorsiflexion, it could be due to either an osseous or a soft tissue impingement. And especially if it's a soft tissue impingement, one of the interventions that we can do is a grade 3 or 4 mobilization to increase dorsiflexion. So for that intervention, you're going to have the patient in long sitting or in supine. And you're going to grasp the neck of the talus and provide a posterior mobilization.
Proprioceptive training is necessary to maintain ankle stability. As treatment progresses, the training should look more like functional activities that are specific to the patient's activity demands.
Proprioceptive training should be at the forefront of your treatment and can include tasks such as single leg stance. And you can also add an upper extremity task to make it more difficult, like something like catching a ball.
Peroneal strengthening as a component of neuromuscular training is recommended in cases of chronic lateral ankle instability to improve dynamic stabilization of the ankle, which in return will help decrease the underlying cause of anterior ankle impingement. Neuromuscular training should be progressed to include multiplanar dynamic movements targeting activity limitations specific to your patient. For an example, an athlete's demands could include running, cutting, and jumping.
Another intervention that you can do, and you can also teach your patients to do at home, is peroneal strengthening with a resistance band. So what I'm going to do is just loop the resistance band and tie a knot. And just place it around my foot. And I'm going to use my other foot kind of as a pulley to stabilize. And I'm going to bring my foot into eversion.